Good morning, and thank you, everybody, for attending today. I'd like to spend a few minutes to speak about the role of orthodontics in dental facial orthopedics, the cleft lip and cleft palate and craniofacial team. It's an honor to be here. It's also a huge honor every month to work with these fantastic doctors in the NGF cleft and craniofacial team, and it's really an honor to participate today. I'm going to give a survey of what we as orthodontists try to do to contribute to this whole amazing process. Dental facial orthopedics can be defined also as early treatment, favorable modification of skeletal growth and development, growth modification in the sagittal, vertical, and transverse planes of space, while we try to effect a guidance of eruption of the permanent teeth into the dental arches. And also, as orthodontists, we try to prepare the skeletal foundations and dental arches for fixed or removable appliance therapy to optimize the surgical outcomes as well as the final dental occlusion. As we all know, the normal growth of the face is in a downward and forward direction, and we also know that much of the growth happens in the facial rather than the cranial structures postnatally, and we use that to our advantage as we're modifying growth and development. Some common dental facial deformities that we deal with in NGF is cleft lip and palate, of course, cleft palate, PRO band sequence, hemifacial microsomia, apron syndrome, Crouzon syndrome, Russell-Silver syndrome, and also severe class 2 and class 3 malocclusions that occur either as a portion of a syndrome or a malady of some sort, but also just patients that present with those genetically. And also we have degenerative joint diseases and other forms of dental facial disharmonies that occur. For orthodontic and orthopedic treatment, we as orthodontists use maxillary skeletal expansion significantly. We also use functional appliance therapy, both fixed and removable. We use extraoral traction, commonly called headgear, or if it's reverse pull for the class 3 cases, we use face mask. Fixed appliance therapy, also known as braces, removable appliance therapy, clear aligners, and a combination of orthodontic therapy with dental alveolar surgery, orthognathic surgery, plastic surgery, and other adjunctive surgical procedures. So as you've seen from the previous lectures this morning, done so expertly, with the cleft lip and palate patients, the patients are treated from the time of birth until the attainment of full physical maturity, so it's a full scope lifespan kind of treatment. There's a series of ongoing treatments that have been just discussed with nasoalveolar molding and plastic surgical intervention. And my role often is maxillary skeletal expansion, which is effective to create an optimal environment for bone grafting, to begin the bony integration of the maxillary segments and to aid in guidance of the permanent teeth into the arch. So I'll jump right into a case treated by NGF. This is a patient, it's a bilateral cleft lip and palate, an adopted child from China. You can see here's the variation of what we see, and here's the patient. This goes with what Dr. Warren just showed with having the premaxilla in a certain place after successful nasoalveolar molding, but of course the segments, the posterior maxillary segments and the anterior segment don't mesh. So it was my job to take the maxilla, expand it as much as possible so that we have the lateral maxillary segments buckle to or outside of the mandible, and then once I expand to the proper amount, then turn it over to Dr. Warren, the plastic surgeon, for the bone graft. This is a typical, what we call a fan type expander. In this particular case, we use the standard Hyrax type of expansion appliance, but since we needed a little bit more expansion in the anterior segment prior to the grafting surgery, we used a fan type expander, which is also a simple jack screw. So this is the patient immediately post-expansion, but pre-surgical. You can see that the buccal shelves in the posterior segments are now buckled to the mandibular buccal segments. This is just a graphic of the bone graft itself. And here's the patient following the bone graft surgery, maintaining with a removable clear plastic Essex appliance, maintaining the expansion that was achieved previously, which you can see very definitively. Dr. Warren's bone grafting has meshed the posterior and anterior segments. Here's an occlusal view, the same. You can see the very definitive area where the premaxilla and the posterior maxillary segments don't mesh, and here you can see a nice smooth transition between those segments. And from the lateral view as well. Sometimes also we see patients that have simple cleft, not simple, but cleft palate only and no lip involvement. And with that, we have a whole host of other discrepancies that we end up having to deal with. There are dental anomalies that present themselves as well in the cleft palate patients. There's just a representation of cleft palate only. This is a patient Dr. Brecht and I saw had a significant clefting of the palate, but you can also see, and a severe maxillary skeletal constriction. You can see on the primary teeth there's a heck of a lot of attrition and wear and tear on those teeth just because of the poor relationship of the arches. And the patient also presented with a cyclops tooth. So in treating this patient, we used standard expansion. We got about 1.5 centimeters worth of expansion. We also had the cyclops tooth extracted, and we utilized the adjacent teeth to substitute for the central incisors and lateral incisors, and prepared the patient for maxillofacial prosthodontics after his orthodontic therapy. So here he is after consolidation of those anterior segments that really weren't meant to be central incisors at all, but we substituted them for that. And you can also see, if you look from the frontal and from the occlusal, the maxillary posterior segments widened out quite nicely. In fact, sometimes it's a little too easy with the clefting of the palate. This is the patient after consolidation of that space and just immediately posterior expansion of the maxilla. At this point, it was time for the orthodontics, and with the orthodontics, we were able to get what we call a proper buccal occlusion with the cuspid guidance and such, and we spaced out the anterior teeth so that Dr. Brecht can come back in and do his beautiful prosthodontic work, as you can see here. So when you look at the post-expansion and consolidation smile, that's where the patient was. Here's his timeline with expansion and extraction and orthodontics without the prosthodontics in there, and here he is from the lateral side. And we also see it in NGF. We see a lot of folks with PRO band sequence, and more often than not, they're treated with, when it's necessary, they're treated with osteodistraction. I don't really have anything to do with the osteodistraction portion, but after osteodistraction, we often, when the patient grows a good bit more, we utilize fixed and removable functional appliances to try to further reduce the class 2 malocclusion, as well as to keep the airway as patent as possible. That's a representation of the PRO band sequence you can see with the severe mandibular deficiency and airway constricture. This patient came to me at almost 11 years old, having airway issues, severe constriction of the maxilla, and significant class 2 malocclusion. You can see it really, it's more obvious in the face than it is in the dental alveolar segments, but you can see the severe constriction here. We treated the patient with a combination of an expansion with a fixed functional or Herbst appliance to bring as much mandibular protraction and maxillary retraction as possible. You can see the actual telescoping arm here that helps push the mandible forward and the maxilla back almost with a headgear effect. We also utilized the fixed appliances in the anterior segment to prevent those front teeth from being targets for elbows, knees, and soccer balls during the process. Here's the patient after fixed orthodontic therapy and after functional appliance therapy. You can see that there still is a bit of class 2 malocclusion there. We fully expected her at this point, she was 15.8, to continue to grow and probably will be in need of, at full physical maturity, usually around between 18 and 21 in female patients, probably a bimaxillary advancement surgery to both move the maxilla forward and the mandible forward to improve airway patency if she needs it, as well as dental facial aesthetics. Now, sometimes we see in NGF, we see patients with severe anterior open bite malocclusion as well, which relates to very often speech and feeding issues, as well as psychosocial issues with the patient. So with a patient like this, there are many different ways that we can go about it, but just so you can see it, it's very helpful to close the anterior open bite while we expand the posterior segments in order to get them a functional bite and to try to optimize the relationship of the maxilla and mandible. In this particular case, a functional regulator or a Frankel 2 type appliance was utilized to try to close the bite. We got a decent amount with that appliance, probably over about 1.5 years, and we then went straight to fixed skeletal expansion of the maxilla, got even more bite closure, but also got the permanent teeth to come into place, and then followed up with fixed orthodontic therapy to try to attain cuspid guidance and incisor guidance after that. And we've been following her year after year. She finished this treatment in 2020. I see her approximately once a year and yell at her to wear a retainer, which she does sometimes and sometimes she doesn't. But I do see in her case, probably, if she allows me to be a critic, a genioplasty in her future to help with lip competence as well as dental facial aesthetics. Now, this is an interesting patient that started with the, I believe, craniofacial work and had NAM with Dr. Brecht, and then moved away and then came back to New York with full fixed appliances on there. So he had history, as I said, nasoalveolar molding, some surgeries, lip and nose, 2 rounds of orthopedics and maxillary skeletal protraction. This is all outside of my purview, as well as some prosthodontics to reshape his cuspids. The lateral incisors were congenitally missing, so they were substituted by the orthodontist. When the patient moved back to the area, the patient transferred to me via Dr. Brecht to finish up the orthodontics. At that time, he was about 15, and we had a suspicion that once we finished the orthodontics, he may grow unfavorably and then require surgery later in life. So this is where he was at transfer. This is where he was after we got some good dental-alveolar expansion, substituted the cuspids with some positive overjet, and we retained him here and watched him, and he did return to Dr. Brecht at 23 years old with edge-to-edge occlusion. He wanted Dr. Brecht to do his signature beautiful laminates, and Dr. Brecht refused because he had the end-to-end bite. So what we did was we then prepared him for surgery utilizing fixed appliances, decompensated the arches, and got him into a definitive negative overjet, planning him for a maxillary Lefort 1 osteotomy advancement. Patient also had aesthetic concerns. As Dr. Warren just mentioned, he wanted some mid-face fill. He wanted his nasal tip to be a bit different and wanted to have more of a straight profile. Just an illustration of the maxillary deficiency, what the osteotomy looks like and how it's plated. And here's the patient just immediately post-op. So with his fixed orthodontic appliances on there, was on me to try to get the buccal occlusion and the incisor occlusion so that they would be conducive to the prosthodontic therapy that he wanted to achieve. And here he is after Dr. Brecht's beautiful handmade laminates. So here's his sequence of events as he grew and developed. Now, I think I'm at about my time.
You can finish up.
I think what I'll do is go in the wrong direction. I've got a couple of other cases, but only if I had gone to the time. So I do want to summarize and say cleft and craniofacial patients usually require a long-term strategy necessitating multiple treatment methods with a team of specialists, as you've seen, working together to affect the desired results. My end of the early treatment entails modification of growth and development via orthopedic therapy, as well as intermediate and subsequent therapy, which involves revision, orthodontics, and treatment including skeletal and soft tissue procedures to optimize clinical results. I wanted to acknowledge the Next-Gen Face Cleft and Craniofacial team. It might sound like a platitude, but it's a profound honor to work with these wonderful doctors and team, and I really enjoy every bit of it. I'd also like to, in memoriam, acknowledge my mentors, my father, Dr. Donald Bronsky, who treated cleft patients during his career, as well as my department chair, Dr. William Prophet, and also Jenny Liu, my world-class correspondence coordinator, who always helps me make these PowerPoints doable. So thank you very much.